Well, this is Imran Rashid. I made this case presentation in collaboration with Kathleen Young. It's a neuropsych case that we saw at Henry Ford Hospital in Detroit earlier this year. So, a 19-year-old female presented with altered mental status and recurrent seizures for 1 month. Her episodes would look like unresponsive, rotating her head to the left, sticking her tongue out, and tremors in her left cheek and hands, and also sometimes urinary incontinence as well. After these episodes, she was responsive immediately, but lethargic and a bit slow and delayed. She has had multiple medication changes recently. First being put on levetiracetam, changed to lacosamide after side effects were not tolerated, and then to brivaracetam after that was ineffective and she was continuing to have seizures. She was seen at multiple facilities for this as well, multiple different hospitals. Then on the 13th of March, she experienced a psychotic episode, was admitted to a psychiatric hospital, Kingswood, and then transferred to the medical hospital after she was found to have an elevated CPK, and was continuing to have seizures. Family is concerned about psychiatric involvement. Um, she has no recollection of these events, but her brother and family endorsed that she was yelling kill him" at the top of her lungs, and other examples of psychotic behavior. For her review of systems, it was largely negative. For her HEANT or cardiovascular, respiratory, MSK, and integumentary, all negative. And then for her neuro review of systems, positive for seizures and positive for altered mental status. More histories on this patient. So these seizures are not new. She has a past medical history of epileptic seizures since earlier in her preteen years. And also PNES has been documented for her, which is psychogenic non-epileptic seizures. Some people would say faking seizures, or often related to a primary psychiatric disorder. And then no previous surgeries. The meds she's on currently lacosamide 100 milligrams BID, valproate 500 milligrams Q8, brivaracetam 50 milligrams BID, and then Haldol and lorazepam as well. She's got no known allergies and no significant family history, especially no neurological family history. And then for her social history, she doesn't use alcohol or tobacco, but she does use cannabis. And then per her mom, she is in a at least emotionally abusive relationship with a male partner. Unsure if there's physical abuse or other types of abuse. And she did not complete high school. Again, she's 19 years old. For her vitals, labs, and also further studies, she got an EEG done. Her vitals are largely stable. She's a bit tachycardic, afebrile, and tachypnic as well, but satting fine. And then a routine EEG was done that showed active seizure in the right hemisphere. She's had previous EEGs done at other facilities that showed maybe one spike, not active seizures. But here at Henry Ford, who was found to have active seizure. And then from her labs, slightly low potassium, a bit low carbon dioxide. She is tachypnic again. Low BUN, low calcium, and elevated AST are the remarkable labs for her. Now, for our differential diagnosis, first, could this just be status epilepticus, recurrent epileptic seizures, a development of her past issues worsening? Could it be PNES or acute psychosis? Also on her differential, anti-NMDA receptor encephalitis, which can be seen in young women. And metabolic disturbances such as electrolyte derangements, multiple sclerosis or another demyelinating disorder, and then finally drug toxicity or substance withdrawal. could be a cause of her seizures. So for imaging, she received an MRI brain with and without contrast. Um, and the remarkable findings from this are patchy hyperintensities, especially of her left cerebellum on flare. And this can be suggestive of encephalitis. And here we have an arrow pointing to some areas of hyperintensity. Now, for our diagnosis, ultimately she was diagnosed with anti-NMDA receptor encephalitis. Suspicion arose due to her demographic and also the recurrent nature of her seizures, along with psychosis. And then a CSF analysis was done that found NMDAR antibodies in her CSF, which help nail down this diagnosis. So the pathophys is typically IgG antibodies that target these receptors in the brain. They lead to inflammation, neurotoxicity, and then an array of symptoms, which include psychosis and seizures that we saw in her, memory deficits, which we saw in her, movement disorders, autonomic instability, and dysautonomia. Um, the diagnosis again is made with clinical symptoms, CSF analysis for the antibodies, MRI findings can be helpful, and then also exclusion of any other conditions. For the treatment for this, immunotherapy, um, typically with plasma exchange, steroids, IVIG, or supportive care, and then treatment of any underlying tumors. Why do we talk about tumors? Because it's can be associated with ovarian teratoma, is a common association that people know for this type of encephalitis. And she was worked up for this. She received a CT of her abdomen and pelvis, and no primary malignancy was found. So, unknown etiology in her case of what caused her to become sensitized to these and produce these antibodies. So these are the references used to create this presentation, and that's all. Thank you.